Hey everybody, Dr. Eric Balcavage. We're back for another edition of Thyroid Thursday, and today we're doing a kind of a lab review. I have a new client I just started working with who's kind of gone on a little journey. Initially had some hypothyroid signs and symptoms, went to their medical physician, had some labs drawn, and he said they don't have a thyroid condition. Frustrated, they wound up going to see an integrated practitioner. That practitioner diagnosed them with a thyroid condition and started treating them, and that led to some initial improvement, but then now the person has all kinds of hypo and hyperthyroid symptoms, yet they're being told by their clinician that their labs are optimal. Okay. I ran a more comprehensive thyroid panel on them, and we can see that the patient's labs, even though their doctor may think that their labs are optimal, are far from optimal. All right, so let's get into it. So these are the labs that the medical doctor ran. They ran a TSH and a free T4, and that's it. So by medical standards, to diagnose primary hypothyroidism, you would need to have TSH lab high and a free T4 lab low. And they typically would want to see that TSH level over 6, over 10 before they actually started some treatment. So this medical doctor said, no thyroid condition, no thyroid problems, no treatment. Gave some lifestyle recommendations, but the patient was frustrated, and so they go to see a more functional or integrated practitioner. These are the labs that practitioner ran. TSH 2.57. So it's about the same range that the medical doctor's labs were. But they ran a few more tests. They ran a free T4, same area, 1.42. Free T3 is 2.7, and reverse T3 is 17.2. Thyroid antibodies were run, they were normal. I did this calculation of the free T3 to free T4 ratio. Now, the integrated practitioner said that this person did have a thyroid problem. They have hypothyroidism because this lab value was not in the optimal range between 1 and 2, and because free T3 was too low, reverse T3 was too high. So the treatment the patient was on NP thyroid. So they're given some NP thyroid. They played with that dose for a bit. Didn't seem to, initially they felt a little bit better, but then they started on separate T3 medication on top of the NP thyroid. They do this strategy for 6, 7, 8, 9 months. And the patient now has lots of hyperthyroid signs and symptoms, brain fog, fatigue, irritability, insomnia. Their GI tract is a mess. They just don't feel well. And their doctor has told them, based on their current dose of medication, 30 milligrams of Armour and 55 micrograms of T3, that their labs are optimal. So we run a full thyroid panel, and here's what we see. By the doctor's standards, they wanted the free T3 between 5 and 6. So by that doctor's standards, they're at 5.8. That doctor thinks this is optimal. And they want this reverse T3 as low as possible. It was 17 before. They want this under 9. It's at 6.2. They're told labs are optimal. When I look at these labs, I took them totally differently. So TSH is 0.019. That means that this person's, all this medication that they're taking, they took it before the blood draw, is suppressing the thyroid gland. And it's probably suppressing that thyroid gland the vast majority of the day, which is causing what? Probably atrophy of the gland. So the gland's not making any T3 at this point, but it's not making T4 either. So if we look at the total T4 level at this point, the thyroid gland's production is lab low. I mean, this person doesn't have enough T4 in circulation in reserve. Now, why is that important? Because people would say, well, T3 is the active hormone, we'll just flood you with T3, it doesn't matter. Because cells bring T3 in, that's true, but a lot of cells, they bring some T3 in, but they bring T4 in so they can self-regulate their own metabolism kind of independently of the amount of T3 in the bloodstream. So, and the T3 that's made by T4 to T3 conversion inside the cells hangs out in the cell longer, and you get a longer lasting benefit from it. So this is too low. So this physician is actually creating a hypothyroid state for the patient. The patient didn't have glandular hypothyroidism before, but they do now, okay? Their total T3 level is 265. Lab high is 180. Why does this person need a T3 level of 265? Well, They don't, okay? That high level of T3 is creating a hyperthyroid state. That's why the patient has all this anxiousness, anxiety, irritability. The problem is this physician probably never ran a total T4 or total T3. They were really only focused on the free hormones. This is one of the reasons why I always emphasize running the total hormones, okay? Now, free T4 is 0.8. This is lab low. This is, and I guess for this physician, they don't care because they're trying to optimize T3, so they don't care so much about free T4. But this is lab low. That makes sense for the lab low T4. Free T3, we already talked about it. It's at 5.8. It's in their sweet spot, so they're happy. And they're happy with this reverse T3 at 6.2, but they don't have much T4 in the system. So because they don't have much T4 in the system, they can't make much reverse T3. But still, with a total T4 of 2.4, that to me still seems like it's too high given the low T4. So what's going on here? This is a person, if I looked at this, if I saw this set of labs, there's no way I would recommend a clinician to put them on thyroid hormone. They don't need it. We don't know their total T4 and total T3, but if I looked at these labs, TSH is 2.57, free T4 is 1.42, free T3 is 2.7, reverse T3 is 17.2. This is a person who has a gland who can make enough thyroid hormone. There's enough T4 in the system. There's probably plenty of T3 in the system, okay? The body is favoring the conversion of T4 to reverse T3 over T3. Why? Because there's probably a cell stress inflammatory mechanism going on. So the body's adaptively decreasing the conversion of T4 to T3. TSH is up a little bit because there's reduced T3 in circulation hitting the pituitary. So the pituitary is saying, hey, thyroid gland, help make a little bit more T3. That's why this is higher. It's not higher because the physiology is broken. It's higher because the peripheral conversion of T4 to T3 is being downregulated. So the pituitary gland is saying, hey, thyroid gland, make a little bit of extra T3 because the peripheral tissues aren't doing it because of the inflammatory cascade. So this person got put on thyroid hormone, probably never needed it to begin with, okay? And once they got started on this carousel of adding thyroid hormone, it created issues. So you give them a little bit of T3 medication, they feel a little bit better because the cells get it. But if you have this cell stress inflammatory mechanism going on, in time the body deactivates it. So what do? They give more TSH or give more T3. As the T3 goes up, they feel a little bit better, but it doesn't last. So then they need more. And as they're doing this and cranking up the T3, what's it doing? The pituitary and hypothalamus are getting saturated with thyroid hormone, and that's suppressing TSH. And that suppressed TSH is then causing the thyroid gland not to make enough thyroid hormone. And then the patient doesn't, as the T3 starts to wear off because it has a short half-life, there's not enough T4 in the system to convert to T3. So what happens? They feel more hypothyroid, so they give them more T3 medication, and initially they feel good. But then more T3 medication suppresses TSH, and now they're losing more T4. So this becomes the vicious cycle. This is how people wind up on higher levels of T3, because it's like giving them a little bit of a drug, like crack or cocaine. A little bit makes you feel good, and now you're constantly chasing the high. So if you've been in this situation, the reason you start to not feel well as you start to take the T3 medication, it starts to the benefits start to peter out, is because you already have an immune inflammatory process going on that's adaptively decreasing the conversion of T4 to T3. It's not broken physiology. And then when you start forcing thyroid hormone into the T3 hormone into a system that doesn't need it, you do raise T3 levels, but you create a glandular hypothyroid situation many times, and two, you upregulate the sympathetic nervous system, that fight or flight response, you make that worse. And three, that flood of T3 into the system creates oxidative stress that can create more cell damage and inflammation. Not a great strategy. So what would I do with this patient? If this patient came in at this point, we would look at habit, behavior, lifestyle. What's triggering this person's cell stress? Is it gut-based issues? Is it organisms? Is it toxins? Is it relationships? Is it mindset? Like, what's contributing to the excessive stress load and the inflammation, and address that. What would we do with a patient that walks in the door like this? The number one thing that needs to happen is this person needs to start titrating their thyroid medication down. We need to work with a prescribing physician to start dropping this dosage slowly and steadily so we can get them into a more appropriate range and see if the thyroid gland can recover, what's an appropriate dose. But this is not an optimal level of thyroid hormone, in my opinion. And even though this person was told their thyroid levels were optimal, they're not. There's no way they are. This is not even close to optimal in somebody. So, hope that helps. If you're one of those people who's kind of been through this rodeo and you need help with your thyroid physiology, you can DM Discovery and my team will send you a link. You can schedule a complimentary discovery call. We'll see what's going on with you and your health and let you know what maybe we can do to help you get better as well. All right, take care.